Welcome to Module 2 in Disease Management. This will be on ARDS. When looking at ARDS, or acute respiratory distress syndrome, it is important to understand how you get ARDS. ARDS can happen in a number of ways. They're typically broken down into direct or indirect exposures. Direct exposures would typically consist of when the organism has direct contact with the lungs. So aspiration, where a normal flora of the mouth causes bacteria to get into the airways of the lungs, causing damage and inflammation. Drowning or burning, where you have water or flames making it down to the lungs and causing inflammation in that way. Or a hemorrhage or anything of that sort would cause irritation in the airways and an ARDS type response. Indirect manner, like any infection that happens anywhere in the body, it gets in the bloodstream, the infection then goes to the lungs. That would be an indirect way of getting ARDS. Pancreatitis, transfusions, these are all indirect ways where infection can enter the body and then go to the lungs and cause ARDS. Acute respiratory distress syndrome is a syndrome basically where, whether it's indirect or direct, there is a shift in the alveolar pressure of the lungs. Fluid then gets into the alveoli and it causes damage, in a nutshell. This impairs your ability to exchange CO2 and get oxygen into the blood, which is basically our lung function. And the inflammatory process is typically caused by cytokines and other inflammatory processes from the neutrophils coming into the lungs and causing direct damage to the lungs. So when you have ARDS, how do you correct the issues in the lungs to get more oxygen in it? And should say, how do we correct issues with oxygen? But our first, when we have the patient, depending on the FiO2 or oxygen we're on, so let's say we're on 40% oxygen and our patient is now desatting. The first means of helping oxygenation, and this is typically on a mechanical ventilator, is to increase oxygen or increase the FiO2. I recommend going to 60%. Once we get 60%, that means that we have a physical process in the lungs that's causing oxygen not to get to the hemoglobin. So then we increase mean airway pressure of the patient's lungs. We can do mean airway pressure increases in a number of ways, through PEEP or eye time, or increase respiratory rate, or increase tidal volume. Now, only two of those are desirable: increasing eye time or increasing PEEP. When we increase respiratory rate and we increase tidal volume, we start to cause more issues rather than fix them, and more stress and more strain to the lungs. So holding the lungs open for a longer period of time and recruiting airways is typically the fix in this situation. We can change vent modes. Pressure control or APRV or bivent are typical modes that we like to run to help recruit the lungs, hold them open, and get oxygen in the blood. APRV and pressure control, these modes need to be trended by the clinicians, and they need to know how to run these modes whenever they switch over to them. Because if you're not paying attention or you're not understanding compliance changes, you actually cause more harm to the patient than good. So it takes competence from the provider. GLD is good lung down. Positioning. You may have portions of the lung that work better, and you want those regions down, because then that's going to make more gravity go pull blood to those lung regions, and it's going to help pick up oxygen. Proning. With COVID, proning was a game changer. Proning helped us get oxygen in these patients that we could not oxygenate. When we look at the CTs of the patient, their posterior bases were typically infiltrated and had the most problems. We would put them on their anterior apical regions, and those patients' oxygen would start to improve and help us to get out of extreme situations. Recruitment maneuvers where we jack up the PEEP to 30 to 40 for 30 or 40 seconds, and we hold those lungs open, try to recruit them, and then we come back off of them. Now, mean airway pressure increases like PEEP and I time, as well as recruitment maneuvers, can cause blood pressure drops by causing interpulmonary shunting. So you want to watch your blood pressure when you do this. Inhaled prostaglandins like ileopros or inhaled Velitri or inhaled nitric or inhaled, these are for pulmonary hypertension. They're a pulmonary vasodilator. So when you have lung regions that work better and non-lung regions, those medications go to areas of your lungs where they work, and they dilate those vessels and help more blood flow get through. It's like a quick VQ fix, a ventilation perfusion fix. And then in the worst situations, ECMO. So you need to rest the lungs. You place them on a machine that will oxygenate and ventilate, remove CO2, and you place that back in their body and you allow lungs to rest. If you look at the image that I have here, this is a helmet that we used during COVID patients and tried not to intubate them. So this is a pressurized helmet that allowed the patient to breathe in and out and stay awake and not sedated and getting into tracheal tube. And it helped the patient for periods of time. It was something that rose during COVID and tried to become a solution for it. But COVID was a process that we hadn't seen and allowed a lot of lung damage, and COVID typically caused ARDS in these patients. We just talked about tactics on the ventilator that we can do. There are other treatment methods off the ventilator, not off the ventilator, but on the ventilator, but not particularly that the respiratory therapist would do. Paralytics, whenever you have a patient like this, they can clamp down or make worsening compliance of their lungs. So paralyzing this patient along with sedation is key. And I recommend not doing paralytics if you can get away with it. But if you have to use paralytics to help compliance and oxygenation, then you have to do it. Proper sedation for blood pressure management and to make sure the patient doesn't remember all the processes that you're performing. Steroids, so this is an inflammatory process. Steroids are to reduce inflammation, so they're essential for management of the patient. Typically solumedrol. Bronchodilators, so albuterol would help with this. And then what is the cause? Is it aspiration? Then we get a bronchoscopy, or we can do a mini bowel, and we can figure out what antibiotics we need. If we culture them, find viral or fungals, we can give antifungals or virals and treat that. And diuresing, you have a CRRT machine over here. People with ARDS typically have renal issues, and they need dialysis or continuous renal replacement therapy. Diagnosing ARDS can be complicated in itself. The first thing I like to look at is a PF ratio. When you have a PF ratio, you should be using this for most of your patients, but it's understanding how well they're oxygenating. When I have students and I give them an oxygen saturation, I say 95%, and they just look at me like, oh, that's good. Well, I understand how much they understand oxygenation, and if they do or don't ask me, well, how much patient's the oxygen on? Or how much oxygen is the patient on? So it always needs context. If the SAT's 95 and the patient's on 100%, that's pretty bad. the set's 95 and the patient's on room air, well, then that's all right. So a PaO2 from an ABG divided by an FiO2 from the patient on the ventilator will give you a ratio, and based upon that ratio, it can signify if you have ARDS or not. An X-ray, if you have infiltrates in 2 or more segments of your lungs, in this X-ray I've included, it's a ground glass opacities that's diffused throughout the lungs. This would be a check mark for ARDS. An echocardiogram will look at the heart function. Heart and lungs run hand in hand, so if the heart has a complication, it can make it look like the pulmonary process has a problem. So if you rule out that there's no LV dysfunction or RV dysfunction, and you don't have shunting of the cardiovascular system, then that's another check mark for pulmonary process. And we look at the lung compliance of the patient. So if they have high compliance, they have high plateau pressures and high peak pressures, that's another check mark for ARDS. The weird thing with COVID patients is they typically didn't exhibit early bad lung compliance. Their lung compliance got worse over time, and they created pulmonary fibrosis very quickly. And then at the further into their ARDS process, they started exhibiting signs of bad lung compliance. And I'm going to wrap up here with the PF ratio, or the Berlin criteria for ARDS. When we look at ARDS and grading it, mild is 201 to 300, moderate is 101 to 200, and severe is below 100. So for example, if you have a patient that is on 100% oxygen and they have an 80 PaO2, 80 divided by 1 would be 80. That'd be severe ARDS. And that again, it gives us context to how well our patient is oxygenating. So this PF ratio typically only applies on a ventilator. I do use it at times on non-invasive or BiPAP ventilation to kind of convey how bad oxygen could be, but you really don't want to get into the Berlin criteria unless you're on a ventilator. It really doesn't apply until you've maximized the amount of intervention you can do with the patient.